Hi, my name is Hannah Lindsay. I'm a research associate at the Traumatic Brain Injury and Concussion Center at the University of Utah School of Medicine. I have a PhD in experimental psychology and I specialize in cognitive neuroscience, but I have several years of training and experience in neuropsychological assessment in clinical, forensic, and research settings. In this lecture, I'll be giving a very brief overview of important things to consider when interpreting data that is collected during a neuropsychological evaluation. The topics that I discuss are particularly relevant to clinical and forensic neuropsychology. However, they do also apply to research settings. During a neuropsychological examination, a wide range of qualitative and quantitative data points are collected to comprehensively assess an individual's cognitive, emotional, and behavioral functioning. These data points provide valuable information about the examinee's strengths, weaknesses, and potential neurological or psychological issues. The integration of these data is critical for forming a holistic understanding of the individual's neuropsychological profile. This integrative process enables the neuropsychologist to provide a tailored and informed assessment of their strengths and weaknesses and recommendations for the individual's specific needs. Background data are essential for providing the context in which current observations of the examinee's behavior and test scores can be best understood. Background information is typically collected through a clinical interview, along with a review of relevant educational, work, and medical history records. The interview provides insight into the individual's daily functioning, emotional well-being, and subjective experiences, while educational or vocational assessments, school or work records, and feedback from teachers or employers can provide information about the individual's adaptive functioning and real-world skills. Another critical form of data collected during the exam are naturalistic observations. Throughout the assessment, the neuropsychologist observes the individual's behavior, emotional reactions, level of cooperation, and any other relevant nonverbal cues. Behavioral observations can provide very useful information about how the examinee functions outside of the formalized, usually highly structured, and possibly very intimidating testing environment. The way in which the examinee conducts themselves throughout the examination is a useful source of information and should be documented. The examinee's attitude towards the examination and the examiner, the degree to which they do or do not conversate, and the appropriateness of their demeanor and responses can suggest a lot about their neuropsychological status and may provide context to their responses to exam questions. Several types of test data are typically collected during the neuropsychological examination as well. And these include standardized neuropsychological tests, self-report measures, and behavioral checklists and rating scales. Standardized neuropsychological tests assess specific cognitive domains such as attention, memory, language, executive functions, perceptual motor skills, and visual spatial abilities. The results from these tests are typically quantitative and are compared to age and education match norms. Self-reports offer valuable subjective data to complement objective neuropsychological test results, as these include questionnaires and inventories that assess the examinee's perception of their cognitive and emotional functioning. Behavioral checklists and rating scales are often used to gather information from the individual and their close family members or caregivers. These provide insight into the person's day-to-day functioning, emotional regulation, and behavioral in real-world settings. Test data differs from the other forms of data collected during the exam, as it elicits behavioral samples in a standardized and replicable, but somewhat artificial and restrictive setting. The strengths and weaknesses of the testing situation lie in its replicability, which allows for behavioral testing data to be compared between individuals over time or with expected performance levels, but these data are also limited to the behaviors prompted by the testing situation. If available, neuroimaging data and neurological examination results are integrated into the assessment to help understand any structural or functional brain abnormalities. Finally, cultural and socioeconomic factors that may influence test performance and interpretation are considered, ensuring that the assessment is culturally fair and relevant. All neuropsychological exam data can be expressed numerically as quantitative data or descriptively as qualitative data. Quantitative data are numerical representations of observed behavior and can be obtained for various behavior samples categorized according to some principle. Qualitative data includes direct observations of a patient's test-taking behavior, appearance, verbalizations, gestures, and mood, and can provide valuable insights into the patient's life situation and attitudes toward the examination. When considered alone, quantitative scores may misrepresent the complexity of behavior and cognitive functions. They can be over-inclusive and obscure specific aspects of the patient's performance. Likewise, qualitative data also have limitations, including potential distortion due to neurological impairments and the subjective nature of observations. The value of qualitative data becomes clear when formal quantitative results of the evaluation would alone suggest that the examinee is more or less capable than they actually are. The examinee's attitude toward the examination and the examiner, the degree to which they do or do not conversate, and the appropriateness of their demeanor and responses can suggest a lot about their neuropsychological status and may provide context to their specific responses to exam questions. Therefore, it is crucial to include direct observations and qualitative data when conducting neuropsychological assessments to gain a comprehensive understanding of a patient's functioning. So to summarize, test scores alone may lack context and comparability, while clinical observations without standardized testing may lack objectivity. Thus, the integration of qualitative and quantitative data is necessary for a comprehensive and accurate understanding of a patient's neuropsychological status. There are two kinds of behavior that are of special interest to the neuropsychological examiners when assessing qualitative aspects of a patient's behavior. The first is behavior that differs from normal expectations, such as aberrant responses to test tasks. These responses may provide clues about neurological conditions and patients' cognitive processes. The second kind of behavior is gratuitous responses, which are comments or elaborations beyond the necessary requirements of a task. These responses can offer insights into patients' moods, preoccupations, and cognitive functioning. Examining patient responses gained through testing the limits or using standard test material in innovative ways can also provide valuable qualitative information about their cognitive abilities and potential dysfunctions. When evaluating quantitative test scores, it is important to understand that they can be expressed in many forms. Test makers rarely use raw scores and instead report scores as values on a scale based on the raw score of some standardized population. This scale allows scores to be compared relative to others on the same scale. Standard scores based on the standard deviation unit are widely used, as they provide meaningful statistical information and facilitate comparisons with populations of interest. Differences between scores can then be assessed in terms of their positions on the standard deviation unit scale, with differences of 2 standard deviations or more typically being considered clinically significant. Standardized scores are translations of the same scale, based on the mean and standard deviation of a population. The Z-score is the basic standardized score, and it represents how much a score deviates from the mean in standard deviation units. Scores above the mean are positive, while scores below are negative. Derived scores are elaborations of the Z-score, providing the same information but expressed in more familiar scale units like a T-score or a standard score, which is like IQ, or a percentile. Interest comparisons are possible when standardization populations are similar, using the standard deviation as the key for translation. For tests that report standardization data in percentiles or IQ score equivalents, derived score approximations can be estimated from a normal curve as seen here. Normative data refers to a collection of information about a specific population's performance on various neuropsychological tests and assessments. The data is obtained by administering the same tests to a large and carefully selected group of individuals who represent the demographic characteristics of the population of interest, such as age, education level, and cultural background. The results from this group become the reference or norm against which an individual's performance can be compared. Norms are important for many reasons. First, normative data provides a baseline for comparison. By comparing an individual's test scores to the norms, clinicians can determine how their performance deviates from what is considered typical for their age or other demographic factors. Normative data also helps in identifying cognitive impairments and neurological disorders. Significant deviations from the normative data may indicate potential cognitive deficits or abnormalities that require further investigation. Without normative data, it would be challenging to assess a person's cognitive functioning accurately. Norms allow for an individualized evaluation, taking into account the person's unique characteristics and life circumstances. Having access to normative data aids in designing appropriate treatment plans for patients. Clinicians can use this information to set realistic goals and expectations for therapy or rehabilitation. Norms are also crucial for conducting research in neuropsychology and related fields. Researchers can also use this data to study changes in cognitive functioning across different age groups, cultural backgrounds, and other factors. And in legal and forensic contexts, normative data is valuable there as well. It's valuable for evaluating cognitive impairment and determining the impact of neurological conditions on an individual's functioning and capacity. Finally, normative data can also be used to monitor changes in an individual's cognitive performance over time. By comparing current performances to past performance and normative data, neuropsychologists can track improvements or declines in cognitive functioning. It is important to understand that the use of different norms for cognitive tests can result in varying interpretations of results for an individual, which can lead to false positives or false negatives. Finding appropriate norms for each patient can be challenging, and clinicians often collect norms from various sources. Demographic variables such as age, education, sex, and race are related to test performance, and demographically based norms aid in test interpretation. However, there is an ongoing debate about the use of demographic variables and test score adjustments. The development of standardized and normed assessment batteries, such as the NIH Toolbox, aims to provide a comprehensive and culturally sensitive approach to neuropsychological assessment. Impairment criteria is another important consideration when evaluating neuropsychological exam data. Neuropsychologists typically use a criterion to identify whether performance on some tests represents clinical impairment. But this criterion is not necessarily explicitly stated, and it's often unlikely to appear in the clinical reports. The criterion is usually based on a change from the individual's premorbid level of functioning, often measured in standard deviation units under the normal curve, which we saw in the last slide. A change of 1 to 2 standard deviations lower than the premorbid estimate is commonly used to determine impairment. However, the choice of criterion can lead to false positives or false negatives, affecting the diagnosis and treatment decisions. The resulting pattern of changes in performance across multiple tests is also crucial in making diagnostic sense. Furthermore, premorbid functioning data are essential for accurate evaluation, but they may not always be available. Clinicians may need to use smaller, more demographically suitable norms when premorbid data are lacking or not representative of the individual's characteristics. Lastly, the sensitivity, specificity, and diagnostic accuracy of neuropsychological data are important considerations during evaluation. The practice of judging a test's diagnostic accuracy as a measure of its clinical worth in neuropsychology is questionable. Most tests are used to provide a description of an individual's strengths and weaknesses, monitor the status of a disorder, or aid in treatment planning, rather than for diagnostic classification per se. Diagnostic accuracy depends on sensitivity and specificity, but the outcome can be influenced by the choice of populations studied. Different populations may yield different sensitivity specificity rates for the same test. The decision-making process for accurate diagnosis varies among clinicians, and disagreements can arise when symptoms are vague or mild. Histories are complex or incomplete, and test performance patterns are not clearly associated with a specific diagnosis. As previously discussed, it is essential to consider both qualitative and quantitative data from various sources when making diagnostic decisions for individual patients. After collecting all relevant data, the neuropsychologist synthesizes the information to develop a comprehensive understanding of the individual's neuropsychological profile. Integration involves several key steps. First of all of the data points collected during the assessment must be reviewed, ensuring that no crucial information was overlooked. Then the clinician looks for patterns in the test results and qualitative data to identify strengths and weaknesses across cognitive domains. Various possible explanations for the observed cognitive and emotional difficulties must be considered so as to rule out alternative explanations and potential confounding factors. Based on the data analysis, the neuropsychologist develops a formulation that integrates the quantitative and qualitative data regarding individuals' cognitive strengths, weaknesses, emotional functioning, and other relevant factors. The final step is to create a comprehensive neuropsychological report that presents the findings, interpretation, and recommendation for intervention or treatment if necessary.